So it is my extreme pleasure to introduce Dr. Leigh Chapman as the 56th Marion Woodward Lecturer. We are so appreciative of the Mr. and Mrs. P.A. Woodward's Foundation, which has generously supported the annual Marion Woodward Lecture for more than half of a century. Dr. Leigh Chapman, as the CNO, the Chief Nursing Officer for Canada, provides strategic advice to Health Canada, plays a convening role on nursing issues, and represents the federal government at public forums. Leigh is a registered nurse who received her PhD at the University of Toronto, Lawrence S. Bloomberg Faculty of Nursing. Over the past 20 years, she has gained a deep understanding of nursing by working in both frontline and clinical leadership capacities. In addition to her role as the CNO for Canada, Leigh continues to work at a community-based consumption and treatment site in Toronto, where she provides harm reduction services and frontline care. So please join me in welcoming Canada's Chief Nursing Officer, Dr. Leigh Chapman.
Thank you so much. Merci beaucoup and bonjour tout le monde. So, get organized here. So you may have come to see, let's see, the clicker is not working, but that's okay. I can pivot here. You may have come to see this person, and I have to say that it's very uncomfortable seeing yourself blown up in this size on a giant screen. But this is actually a much more personal presentation, more so than I've ever done before. So thank you all for coming. Thank you to Dr. Wong for the warm welcome as well. So a couple of disclaimers. These are not the typical disclaimers that you would see in an academic presentation. They're a bit different, certainly to advise you that I am not funded by Big Pharma. I assure you that I have no funding to receive this talk or to do this talk. And in full transparency, I also could not accept the honorarium for this talk as a federal public servant. But I do appreciate UBC for getting me here safely to the West Coast, and really huge thanks for the wonderful conversations that I was able to have both last night and today. So this is really my account of the last decade. I have been a nurse for 21 years. So I'm talking about the last decade, even though we're still 90 days from 2025. So I hope you'll grant me that indulgence that I've kind of extended the decade from 2015 to 2025. And only 2 of those years are years in which I've been in the federal chief nursing officer role. So, of course, as you know, leadership is a process. It's what we've been talking about tonight. And so together, we're going to walk the path of my leadership journey, where it seemed that my personal and professional lives really collided into something I would never have thought possible or even imagined. I've already mentioned how personal this presentation is, and although I will be touching a little bit on my professional role, that's really just 1/5 of the last 10 years. Or 20%. So I will be describing my journey into advocacy and activism, which is situated contextually within a time and place. And this is not an endorsement of similar direct action at this point in time. We are in an extremely volatile time in this province, in this country, and in North America, and geopolitically around the world. So take that as you will with this important disclaimer. There will be things that I describe that I hope many of you can relate to, and other experiences that may seem completely foreign or frankly not your cup of tea. So this is my invitation to you to take what you will from this presentation and throw the rest away. Please choose your own adventure. And it always feels extra sensational when folks say they're showing you things that have never been seen before. So I will be sharing some images of my family, both chosen and otherwise, in the hopes that I can keep you engaged for the next few minutes. The never seen before footage. And in the era of multitasking and the immediacy of social media and access to information, I ask that you remain here with me in the room, both virtually and in person. I even have this quote from Ram Dass tattooed on my arm as a reminder for myself to do the same, to be here now. And Ram Dass also says that we are all just walking each other home. So I'm very honored to be here and thank UBC for the privilege as we journey together and walk each other home. And just a disclaimer, I'm fully on Eastern Daylight Time and it is way past my bedtime. So this is a bit of a parody slide in my attempt to divvy up the past decade into some clear chronology and some semblance of order for this talk. But of course, there are no clear boundaries, no clear lines between grit, grief, and gratitude. And as many of you can attest, none of us get through this life unscathed. And grief is actually the price of love. So I live every day with incredible grief. And it never leaves us, and is sort of an alchemy happens, where grief just becomes a part of who we are. It transforms us. And the only way we can move forward is through grit and at times naive determination and optimism. And the only way to find inspiration and hope to avoid despairing about an uncertain future amidst so much turmoil in the world is really to be grounded in gratitude. So with that, I'm grateful to be here in your beautiful province. I want to thank the elders, Thelma, Art, and others for the territorial welcome today. And on this week in which we re-examine our commitment to meeting the TRC calls to action. This is a week where we wear our orange shirts, not as performative allyship, but as a personal commitment to reconciliation for the kids who never came home and for the generations who continue to be harmed from Canada's colonial legacy. So thank you also to Dr. Sabrina Wong for the land acknowledgement. I was going to say Elizabeth Sawick, but I hope she's recovering. Thank you for the land acknowledgement in starting this talk in a good way. So many of you have heard me talk about my nursing career before, and we talked a little bit about it on the panel. And most of this, I think you can actually glean from my bio or backgrounder. So I won't belabor my experiences and what led me into the federal chief nursing officer role. But I will say this, I love nursing. Nursing has shaped my identity, my worldview. It's given me so much, both personally and professionally. And it is also through nursing that I've been able to reconcile many of the traumas that I've experienced in my life. Early in my career as a new grad in the ICU, it was actually my nursing colleagues who helped me contend with the fact that the police were often called to my house during Christmas or Thanksgiving dinners because of my older brother Brad's behavior. They helped me reconcile parental abandonment issues with my father through the lens of trauma-informed practice. And they gave me the best foundation for my own nursing practice, sometimes through things I wanted to be sure not to do, but most often through things I wanted to emulate and mirror in just being like my seasoned ICU colleagues. In fact, I never thought that I would leave the ICU, but I eventually did, opting for provincial roles that provided an incredible breadth and scope in enriching my nursing practice. And it was actually after leaving point of care nursing that I did the unthinkable in venturing back to the bedside, as it were, as a camp nurse. I had attended this now 105-year-old Camp YMCA as a child, as did my brothers, and it was where I truly felt like a kid amidst all the turmoil going on at home. I remember buying Smarties at the tech shop and racing around in my wet bathing suit just to have the best time on this island in the middle of Georgian Bay. So this is where I returned to camp nursing in 2015 after being out of direct practice for a few years. But it was also at camp, just a few days into my first year of camp nursing, where that I got a text message from my mom that my brother Brad was in the ICU, brain dead from a drug overdose, and that we needed to go and withdraw life support. So Brad was adopted into our family as a child, and then my brother and I came along. So despite being the eldest, Brad always commanded the most attention. In fact, both of my brothers did, but for very different reasons. And if this doesn't paint a picture of the neglected middle child, I'm really not sure what does. My younger brother, Peter, had a speech impediment growing up, and I was his translator. And then Brad was adopted into our life. And he remained in foster care for 9 months prior to coming into our family for fear that he would have deficits because of his birth mother's substance use. It's hard to do justice to his 43 years in a few short sentences, but I'll give it a try. He was diagnosed with hyperactivity disorder as a child and prescribed Ritalin, which was very 1970s, but it also marked a time in which he was given drugs as a means of being okay in the world. He had a very troubled youth, largely the result of parental separation, which seemed to have an even greater impact on Brad because he felt like he was given up twice. The first time when he was adopted and the second through divorce. He was in and out of youth detention and group homes as a youth at a time when there was little to no regulation about what went on in these settings. He ran away at least once. He then had children starting at 18, and despite being a very loving dad, the trauma of poverty, criminalization, and mental illness plagued him thereafter. And he was actually relieved when he was diagnosed with an almost inoperable brain tumor right near his brainstem. So for the neuronurses, it was in the cavernous sinus of the brain, very, very hard to access. And despite surviving a very difficult 13-hour surgery, his biggest problem post-op was actually addiction. And he spent most of the rest of his adult life both in and out of jail, sleeping rough, or experiencing homelessness. So while these pictures show my brother Brad and our family, so does this. His legal aid lawyer often said that the judges didn't recognize Brad when he had spent time in jail because he looked so different from the man who was initially incarcerated. He worked so hard to survive, and I know he didn't want to die. He wrote love letters to his children whenever he was in jail. He worked out, he read books, he read newspapers, enough to have very intelligent conversations. But once he got out, the same cycle continued, and ultimately he lost his fight in 2015. I won't go into the details of his death because that would exceed the time allotted for this talk, and all of those details are actually available in media stories written about my brother. But I will say his death, like most overdose deaths, are entirely preventable and fraught with stigma and discrimination. And the only way for me to reconcile his loss was a call to action to nurses. So in this Facebook post on August 26, 2015, the day that we withdrew his life support, I asked for nurses to do better because it is often us within the profession who are stigmatizing the most vulnerable. As they say in the horror movies, the call is coming from inside the house. Fortunately, we had incredible nurses in the ICU who cared for Brad, but they were completely perplexed at how this John Doe, who had been critically ill in the ICU for over a week, ended up surrounded by family for the withdrawal of life support. And then I experienced this great indignity and discrimination towards Brad when one of my relatives, former relatives-in-law, said, I forgot he even existed. Just a few weeks after Brad died and when I was still very raw in my grief. And this was at a point where I was completely incredulous to how Brad could have had fall through not just gaps, but gaping holes in our social welfare system. And I don't share this example of stigma and discrimination for pity or empathy. I share it so that you can get a glimpse into the profound stigma and discrimination experienced every single day by people who use drugs. There's a pecking order to deaths, and overdose is one, likely similar to deaths by completing suicide or deaths by violent misadventure, that are considered self-imposed. So in the ranking of noble deaths, overdose might be right at the bottom. And this has important policy implications for us all to consider. I also urge you to consider the stigma faced towards Brad, who despite many challenges grew up in a white middle-class family. To the stigma, if we compare that to the stigma faced by Black, Indigenous people of color, or LGBTQ people, and how compounded their discrimination is. Brad's name was listed on the Toronto Homeless Memorial, where he was flanked by nameless Jane and John Does. And the Toronto Star did a newspaper above the fold profiling Brad entitled The Invisible Dead in a bid to start counting and tracking and thereby preventing homeless deaths. Now, I assure you, I was not looking for a side hustle in advocacy, and in many ways, it felt very humiliating to be sharing my family's worst trauma so publicly through advocacy. But it really wasn't about me. It was about preventing other families from going through the same thing we were going through, and I really had nothing to lose. And so I poured myself into advocacy. I had no idea what I was doing, but again, I had nothing to lose. The worst had just happened, so I figured I might as well help other families in preventing similar tragedies. I gave my first deputation at City Hall in favor of a homeless shelter for men that was slated to open in my community. Despite the community rallying support around shelters for women and children respectively, there was tremendous opposition to opening a shelter for men. Basically, they were all considered pedophiles, drug addicts, and criminals. I was then invited to advocate. Oh, sorry, I just should say that the shelter got approved and moved into the neighborhood where it remains without incident. I was then invited to advocate for supervised injection sites in Toronto. Toronto was putting in a bid to open 3 sites in 2016. This was at a time when I was halfway through my PhD while working and parenting my then 5-year-old. My dad had also died just a few months after Brad, so in less than 6 months, I lost half my family. But again, I had nothing to lose. And I actually felt productive when I was not wallowing in grief, when I was advocating by sharing Brad's stories and writing angry letters to politicians. In 2017, I came out west for a meeting at SFU on scaling up supervised consumption sites. And I know some of you in the room were there. This was led by the incredible Don McPherson at the Canadian Drug Policy Coalition. And I certainly felt like a huge imposter at this meeting because I was just an advocate pushing from the outside and not actually doing the work. But here I was saving a seat beside me for my colleague Rafi, who did never make it to the meeting. Rafi overdosed in his hotel room because he was using a loan, and he could not travel across the country with his own supply of drugs. So he had to rely on the Vancouver market, which he was very naive about, and naive too, despite being a seasoned drug user and overall incredible human. And at this point, I'd been a nurse for 14 years, and I'd been to many nursing conferences and events over the years, and I had never had a nursing colleague die and not make it to the actual meeting or conference. The crisis was killing my friends. And it was through grief that I found community in the network of people who use drugs and harm reduction workers. But it was also through the community that I was experiencing even more grief. So then about 6 months after coming out west, after 6 months of an existential crisis and questioning whether I should drop out of the PhD program, I started a GoFundMe called the Toronto Overdose Prevention Society, or TOPS, which was a signal check to the rest of the country that we were going to follow the BC approach of opening up overdose prevention sites. Now, shortly after the first unsanctioned sites in BC, the declaration of a public health emergency in December of 2016 permitted the opening of OPSs. But this was not the case for Toronto, and I knew that we were risking arrest. But at the time, I thought I would rather do something and risk arrest than watch people continue to die of a preventable cause. I was closely connected to the Vancouver OPS's Sarah Blythe, who I just met a couple of years ago in person after being connected virtually for so many years. And Sarah counseled me frequently at the time about how to actually open an OPS, how to engage with police, media, and politicians alike. And so on August 11th, 2017, together with my TOPS colleagues, we erected tents in Moss Park in the downtown east of Toronto. The municipal politicians were so annoyed at us for scooping their ribbon-cutting opportunity to announce the opening of sanctioned bricks and mortar sites in Toronto, but we knew we couldn't wait. The police threatened arrest, but we impressed the superintendent with our naloxone and sharps container and even stethoscopes. Yes, the other nurse and myself, we wore stethoscopes as a means of showing we were real nurses. And he said that the crisis supersedes the law and he allowed us to stay. And to be clear, there were 3 rules that we were breaking. We did not have a municipal permit to open tents in a park, so that's a bylaw. We did not have permission from the province to open a healthcare facility where we provided naloxone, we administered naloxone, and we had oxygen, and we did not have a federal exemption for the controlled drugs and substances. So multiple levels of rule breaking. But a remarkable thing happened in true Field of Dreams. If you build it, they will come fashion. People came to use the site. They trusted us. They sometimes lined up and waited patiently to use inside our tents. And Torontonians supported us in so many ways. People would show up and open their trunk full of Costco snacks and water for the community. They donated money, and they voiced their support for our life-saving efforts. After a few months in the park, we were eventually able to upgrade our tents, again, operating on a GoFundMe, but we still had to dismantle them every single night. Our operating hours were 4 to 10 p.m., 7 days a week with an entirely volunteer workforce. I managed the budget and volunteered as a nurse and coordinator at one point we had over 200 volunteers. Toronto Overdose Prevention Society was a movement, and I remain so proud to have been a part of it. Because of political changes, TOPS has resurfaced in Ontario just yesterday and issued a press release where they describe themselves as a group of healthcare providers, harm reduction workers, concerned citizens, people who use drugs, researchers, and others horrified by government inaction. We supervised so many injections, distributed supplies in a lock zone, and even changed the landscape of the park, which was really no small feat. We had the mayor visit, we had then Premier Kathleen Wynne visit, and then Provincial Health Minister Eric Hoskins visit. They sat on the floor and they heard stories about people's drug use as part of their quest for survival. They were very privileged to be trusted with such personal tales of such deep humanity. And eventually, by December, we got really bold and rented a trailer to bring into the park. An unknown source connected us to the grid, and we had a heated trailer with electricity that was a safe haven for people who use drugs in the midst of Municipal Park in Toronto. And there we remained until July of 2018. This work didn't end. We rallied, we held demonstrations, we continued to fight to keep our site and others open in order to save lives. By 2018, the political climate had changed in Ontario, which brought additional political scrutiny to sites that had been approved by the previous provincial government. And in one, I think, very funny blending of my personal and professional identities, I brought a 6-foot-tall Grim Reaper into the Faculty of Nursing at U of T, which is hopefully a first for any nursing school across Canada. We watched our friends continue to die, and we developed great skill and expertise in planning memorials. I've delivered more eulogies than I can count, and none of these are skills that I would wish upon anyone. We brought our fight to the provincial legislature, opening a pop-up OPS on the grounds of Queen's Park. We wanted to make a point that the sites could be erected anywhere, and we were really quite simply about saving lives. And this was a family affair. My son got quite involved in this fight for social justice, advocating with me in support of harm reduction services in Toronto, and making friends, sometimes as a surrogate child for those who were estranged from their own kids. Liam and Leon, Pops Allward, he went by Pops, got along famously and were great friends until Pop's death, which devastated us all. And in my favorite action, we erected 1,265 crosses on the lawn at Queen's Park to mark the 1,265 deaths. We were threatened with a bill for ruining the lawn's sprinkler system, but I think it would be fair to call it even, considering all the volunteer hours we put into saving lives and diverting care away from emergency departments and ICUs. So then in 2018, there was a coroner's inquest into my brother's death, and it was actually my TOPS colleagues, my Toronto Overdose Prevention Society colleagues, who rallied to support me and my family with a prepared meal service to get us through the grueling days in court. I mention the coroner's inquest because it's worth noting that we're not special as a family. There are thousands and thousands of coroner's inquests into preventing deaths that occur all across the country. Coroners speak for the dead to protect the living, but we really have to interrogate how they are speaking for the dead and protecting the living when there are no legally binding requirements to implement inquest recommendations. So I have great empathy and solidarity for the countless families who have experienced their family's worst trauma being on display in a public courtroom. It was one of the worst experiences of my life, and it's definitely not for the faint of heart. Now, because I took a plane out here, I thought it was worth including this slide from Toronto Public Health Medical Officer of Health, Dr. Eileen de Villa, who took the stand at my brother's inquest and testified that we're losing an entire Airbus each month in Canada. Excuse me, with the number of overdose deaths we have across the country, 22 deaths per day of an entirely preventable cause. Provincial corrections nurses also took the stand and said, Mr. Chapman is complex, which makes me wonder if and how we are designing healthcare for simple or complex people, and how healthcare structures are impeded within carceral settings. So the inquest ran from November 26th to December 20th of 2018, it lasted a month, and there were 55 recommendations as a result of this inquest. But the first recommendation from the jurors was that all recipients of these recommendations should recognize the urgent nature of the opioid overdose crisis and should consider and implement recommendations with utmost urgency. Eventually, I finished and defended my PhD in 2019, and not only was the happiest person in the Staples print shop that day, and perhaps the only time the photocopier staff has been asked to take a photo of somebody, but I think I was also the happiest person and probably a bit incredulous in that convocation parade. And then COVID happened, and it changed our parenting, our public health approach. It changed the landscape of healthcare as we know it. We had the largest vaccine campaign in Canada's history, and it's safe to say we're still recovering from many of the traumas experienced by our health workforce. The impact of COVID on people like Brad was devastating, and the deaths rose exponentially. And it was during COVID that I had a once-in-a-career opportunity of developing a nursing workforce from scratch in a physician services organization in Toronto for people experiencing homelessness who were impacted by the COVID-19 pandemic. COVID was new for all of us. Caring for people in hotels was new, and the unhoused population was also new for the majority of nurses we hired. And we did not have the benefit of time, and in many ways, the pandemic had really outpaced our work. We had to develop a model of care and a nursing program for people experiencing homelessness. So I was hired on March 20th, 2020, and we were fully operational on April 7th, 2020 in a 24/7 recovery hotel. We recruited nurses via group Zoom meetings, similar to a crash deployment model. I had the privilege of working with some of the best nurses. And despite my tenure being 2 years in this role, I'm pleased to share that the program remains fully interdisciplinary and, dare I say, nurse-led over 4 years later. So then in August of 2022, I was appointed into the Federal Chief Nursing Officer role and given this privileged position of leading from this standpoint. Now, given all I've just talked about and what transpired over the previous 7 years prior to my appointment, I'm sure you can all imagine my surprise when I actually passed the secret security clearance for this position. But I was also concerned about the scrutiny from within the nursing community. I was a PhD prepared nurse with almost no publications because I was busy saving lives in a park. What would the rest of the country think of my publication record? What would the great Sally Thorne consider me as an imposter in the academy because I felt like I was a bit of a fraudulent doctorally prepared nurse? And I share this to impart with you that the imposter syndrome never goes away, regardless of whether you occupy the top nursing job in Canada or any other position. The reality is you just have to do the things scared, even when your voice shakes, and even if you feel like an imposter. And my surprise continued when I was summoned to meet the Prime Minister just 2 months into my tenure as Chief Nursing Officer role, or in the Chief Nursing Officer role. I think my surprise and my colleagues' surprise at Health Canada, if I'm honest. And so, well, some of you may think that I spend most of my days briefing the Prime Minister. That's not actually the case. I've been very busy over the past 2 years engaging with nurses from across the country and with the nursing community, convening various groups and also releasing the Nursing Retention Toolkit in just March of this year. I've been given incredible experiences thus far in my role, and mostly that is thanks to you, the nursing community, for supporting me throughout my tenure. You have embraced the reinstatement of the Chief Nursing Officer role and supported me on this journey. And I've had some really cool experiences to date, even doing a collaborative presentation at the International Council of Nurses Congress with Simon Sinek, the author of Find Your Why. And in all of this engagement, I try to lead with values, stressing the need for unity in the nursing profession, and for leading by centering equity, diversity, inclusion, and reconciliation. I talk often about social determinants of health, about the need to focus on what's best for those we serve as patients, and of course, on providers, and the need to focus on evidence-based policy like harm reduction. So I did promise that I would deliver on some policy pearls. So here's my attempt at trying to knit this presentation together into some tangible takeaways. We need to inhabit the nuanced gray. So politics may seem very black and white, but policy actually occupies the gray space. And this is the space we need to dwell in as nurses in order to advance good public policy. Nursing is and must be multi-partisan. Because of our attunement to social determinants of health, we often veer to the center or left, but we absolutely need to be multi-partisan in order to advance our collective goals as a profession. Health workforce issues can be, and perhaps ought to be, politically agnostic. When we think of some of the workforce priorities like nursing retention, better workforce planning data, and more efficient integration of internationally educated nurses, as well as better labor mobility for nurses across Canada, we have to consider these as politically neutral or agnostic, and thus multi-partisan, which means that we need to keep advancing these priorities regardless of who is in power. We need to think of harm reduction as evidence-based policy. We have to start to see harm reduction on a continuum and of course consider it for what it is, evidence-based policy. How can we work together to depoliticize this topic as essential life-changing evidence-based health and social care for people who use drugs? We are more credible as leaders when we lean into what sparks joy and when we speak with conviction. A good story has the power to sway the hearts and minds of many decision makers. So I really urge you to find your passion and speak from the heart in all that you do. And lastly, a few leadership lessons that I hope to impart from my personal and professional journey that you've allowed me to indulge you with today. So I think it's fair to say that nursing is inherently political. We cannot look away. We need to be involved in shaping the very fabric of society. Nurses have the power to change entire societies, and there isn't a person in Canada who is not touched by a nurse at some point in their life. We need to leverage this for collective action, and in doing so, find our power as nurses. The most important job for any nursing student is to find their voice for themselves, for their colleagues, for their patients, and ultimately for the system. It's not enough to just find your voice, though. You have to use it, even if your voice shakes. We need to do things scared. Clearly, I think it is both our effective strategies in working both with government or from the outside. We need to do both, work with and from within. Sometimes pushing from the outside, sometimes pushing from within. I have certainly benefited from a very rich, varied, and circuitous career in nursing thus far, and I hope you keep an open mind to the art of the possible. For the 11 of my 21 years of nursing thus far, the role that I'm currently in did not exist. So what does that mean for you and your future as a nurse? We need to privilege the voice of people with lived and living experiences. I don't speak for Brad. I speak as a bereaved sister and as a nurse. The two are forever intertwined, and as much as I'm tremendously grateful for his legacy and my journey, I would give it all up just to have him back. We have to be true to ourselves and lead with integrity, no matter the consequences. And there are sometimes consequences to courageous leadership, but we have to be willing to draw a line in the sand to stand up for what we believe in, no matter the repercussions. So in closing, although I was not able to accept the honorarium for today's talk, I have collaborated with the HRNA, the Harm Reduction Nurses Association, and the Canadian Nurses Foundation in creating a Harm Reduction Nursing Award for students studying nursing education programs across Canada. And I'm really excited for this big reveal here tonight for this named award through the Canadian Nurses Foundation. So thank you very much. Merci beaucoup.
Okay, so we are gonna do Slido today for our questions, and I'm gonna hand it over to Leigh very soon, as soon as the questions start popping up. But I wanted to ask if anybody in the room had a question. Yes, please ask your question.
So my question is, I totally agree when you said, when you ended your talk around nursing is politics. And I totally agree on it. And I feel it's politics have a control over everything around us. And as nurses, if we believe in change, we actually have to understand that specific word and how to deal with it. And speaking from experience, because I read a lot about politics, and I think that's part of my PhD journey too, regardless of my belief that, okay, I'm going to create a change. I know I understand the dynamics of the environment around me, but sometimes I feel hopeless. So I don't know how, like, I'm curious. I don't know how actually you continued going. I'm still I'm doing still PhD. I'm still a young scholar, but I'm not sure actually if I face the same resistance as you, I will keep going. And I feel the weight I carry on my shoulder, it looks different, but it's the same. It's like a trauma-informed approach. So I'm not sure I don't know, can you talk around that? Like how to keep moving, how to not to lose hope. Yeah, thank you.
I love that question because I think we have to live in hope. We have to live in hope that, like Megan said earlier, there's injustice everywhere. And I think we bring such a unique perspective to that injustice, from a social justice perspective, from an inequity perspective, from a patient-centered perspective, an evidence-based perspective. There's so many important lenses that we bring to bear on injustice writ large. And I think we have to live with hope and optimism. Otherwise, and it sometimes is like one step at a time, one breath at a time, but sometimes, you can actually set goals and look to the future with optimism. And I think, there's probably goals you have for when you're finished your PhD, and also always keeping that in mind, that staying open, but also staying hopeful and not dwelling in the despair.
Thank you.
Okay, that was great. Thank you for that question. So I have the next question for you, and that is, can you speak more about nursing being political and how we advance our practice in a nonpartisan fashion? How can we hold on to both?
Yeah, and I wouldn't say that nursing is nonpartisan. I said multi-partisan. I think that's an important distinction, that we actually need to think about nursing from different perspectives and what we bring to bear from different perspectives. It's not that it's nonpartisan. It can't be. It's inherently political. But I think that we need to straddle multiple fences, and when we think about the work that we do. And I think it is a moment of, I'm not being Pollyanna in answering this, but I do think it's an and also issue, not a either or. I do think that we can do both. We nurses are responsible for incredible things every single day, and those are the stories that we need to be centering.
That's great, thank you. So how can we depoliticize harm reduction?
I feel like there are many experts in the room who would be better equipped to answer that question. But I mean, the way that I have worked in the space has been really focusing on my brother's story. But I will say the first deputation I gave on, in the homeless shelter that I was advocating for, I was speaking very much as a bereaved sister, but I mentioned that I was a nurse. And the first question I had from the politician was, so as a nurse, can you tell me why you think this shelter is a good idea? And to me, that was a very jarring moment, because I thought that I was speaking from one perspective, but the politician actually wanted to hear from the nursing perspective. And so it was a real galvanizing moment for me to think about the power of the nursing voice.
Yeah, that's amazing. And I think, your storytelling and providing hope is, what we need for nurses across Canada. So I think earlier you mentioned that you said that the position of a chief nursing officer had been vacant for over a decade. And so how do we as nurses never lose the position of a chief nursing officer again? Do you have any insights for us?
Yeah, well, I mean, I think there's a few strategies. I think nurses need to be more politically active in various spaces. We also need to think of the Canadian Nurses Association as our national nursing association. We don't have de facto membership in CNA by virtue of being members of NMPBC here. You have to also join CNA as a separate body, and it's really only through the Canadian Nurses Association that we have standing or representation with the International Council of Nurses. So that's really important from a global perspective. It's a CNA that puts us on the map internationally. And I think, leveraging the power of CNA as a national voice, as well as our provincial associations, as means of not just celebrating or recognizing the importance of the federal chief nursing officer role, but provincial chief nursing officer roles, because not every jurisdiction has a provincial chief nurse. So I think working together from that FPT perspective to make sure that there is a chief nursing officer role in all levels of government.
Okay, that's great. Thank you. So I'm going to ask this question because it's related, and that is, what role can nursing regulators play in moving this work forward?
Well, I think all the priorities I mentioned, so better labor mobility, better workforce planning data, accelerating the integration of internationally educated nurses, that's all in the domain of nursing regulation. And so I work very closely with the regulators. I think they work closely together, but we really need to also work with them to really advance these mutual and shared priorities, because they operate under the direction of provincial government, provincial and territorial governments in the public interest. And so we have an important role in being active in nursing regulation and shaping nursing regulation in our jurisdictions as well.
So, we might have an upcoming federal election. And we definitely are in the interregnum period, as some of our colleagues have said. So how do we continue to have a chief nursing officer role in the event that potentially the parties change? How do we, be multi-partisan? How do we do that?
So I think there's a whole lore to the reinstatement of the federal chief nursing officer role. And some of you may know this story better than I do, but what I'm told is that there was a ton of advocacy within the Canadian nursing community, and it kind of reached a bit of a fever pitch in 2018 at the International Council of Nurses Congress in Singapore, where a bunch of very esteemed nurse leaders from Canada got together and penned a letter to the Prime Minister and sort of shamed him for not having this federal role. And then the lore also says that they got Dr. Tedros from the WHO to write to the PM as well, and sort of say, you're a rich country, 70% of countries around the world have a government chief nurse, you should have a chief nurse. And then COVID happened. So there was really a desire to reinstate the role. But the other piece is, when a role has been vacant for 11 years, there's zero structures internally to support the role. And so it took a long time to actually set the role up structurally within government. And that work has continued through my appointment. But I think we can't underestimate the importance of nursing advocacy, because it really was advocacy that led to the reinstatement of the position. And I think it will be advocacy that will ensure governments at all levels are accountable for the permanence of these roles.
Okay, that's great. So I'm going to ask a related question here, and that is, why do you think nurses are not sitting at the table? One of our colleagues in the earlier panel said that nurses need to be sitting at the table. So how do we get to sit at the table?
Sometimes we have to pull up a chair. I think that, it's an interesting question, because I think we make a lot of assumptions that we should have a seat, without actually making the argument for why we should have a seat. Like we say things like we're the largest group of regulated health professionals, but that's not why we should have a seat because we're so numerous. It's because the role we play. And I think, some of the questions that we were talking about earlier on the panel sort of show the divisions between the profession. Like if you advance into a leadership role, but you abandon your clinical practice, you're leaving a big gap instead of recognizing all the domains of nursing practice. And we need policy nerds like me who are nurses, but we also need practicing nurses. We need everyone in between. We need chief nursing officers, we need faculty, we need preceptors, we need everyone. And so I think by recognizing our collective strength in the myriad roles that nurses play, that's how we get a seat at the table.
Yeah, it's really, you really make me think about what is the problem that nurses are there to solve? What's the value add of the nursing voice? So thinking about how is nursing going to solve the problem and how is that different than other professions? So yeah, really speaking to those issues. Okay, the next question. Let's see. I've lost my place now. Okay, so you touched on the voice is coming from inside the house. Can you speak to the ongoing struggles of incivility within the nursing profession?
I think I alluded to, that's a really ominous quote that I use. The voice is coming from, the call is coming from within in the house, but I think it's fitting. So I think, sometimes I mentioned this as well. We do this with students. We do this with new graduates. We perseverate on everything they need to learn. We, label them novices and keep putting them in their place for, not earning their stripes. We have a totally different generation. We have nurses going into, I went directly into critical care 21 years ago and felt very supported, but that is certainly where nurses are going. They're not destinations, but we still have this archaic model that, nurses need to work 2 years in a med surg floor and then they can sort of graduate to the ICU instead of actually leveraging the workforce and the multi-generational workforce and actually supporting them to enter specialty areas. So, I think in terms of incivility, sometimes there's a lot of violence that nurses experience, but there's also the horizontal violence, the incivility. And I think that there's a lot of elements to that, the gender nature of nursing, press group behavior, like there's a lot that we could look at from a feminist lens, which is also not, feminism isn't about gender also, but I think that we need to really think of the disharmony in the nursing profession, that it's not about all the different divisions, all the different sectors in which nurses work, the different areas of specialty practice. When I think of nursing from a pan-Canadian perspective, it's all nurses. It's 4 categories of nurse. It's the 2 official languages. It's every single area of practice in which nurses work, including very remote, isolated communities and urban centers. It's everything in between. And that's nursing in Canada from my lens. And that's really how we knit the country together through the profession. It's all of us. It's not either or. It's not, RNs over LPNs. It is, or NPs, and over RNs or RPNs. It really is all of us working together and sort of rowing the boat in the same direction.
Yeah, that's great. We all have a role to play in the world of nursing. So I have another question for you, and it is, can you share your insights and advice from the transition from clinical leadership in administrative to strategic leadership, especially for women leaders?
I think strategic leadership is the most fun, I think, because you're not mired in the fires. You're not mired in operational things. I think it's very rare to be in a role that is strictly strategic. That's kind of my role now, a policy role, because I don't have operational responsibility. We fund healthcare, how it's managed and administered is up to the provinces and territories. And I think, when you are in a strategic leadership opportunity, or position, it's an opportunity to really look at models of care, look at nurse-led initiatives, really look at evidence, look at shared governance models, and all of those things that can really transform the practice environment because you're not mired in operations. So, my sense is it's really an opportunity to have that crystal ball and look at what are the initiatives that you can advance within the organization from a strategic perspective that will really propel the organization forward into the future instead of just being mired in sick calls and vacancies and all of those operational constraints.
Yeah, that's really nice. So for those of you who are aspiring to be nurse leaders, to really think about that there's different kinds of leadership, right? So there's operational leadership, but there's also strategy leadership. And I think you were saying that your job right now is about strategy, and strategic leadership is different than the operations, but both are very needed. And as you said, not do you often get to do this strategy, which is so much fun. It's like putting all the puzzle pieces together. So there was a question in here about Chief Nursing Officer, and could you just talk a little bit about the appointment process? Were you invited to apply for the role? And then kind of, you alluded to it a bit about, passing the secret security clearance and all that kind of stuff. And I think it would be really interesting for people to hear about kind of what is it like to become an employee of the federal government?
Well, how much time do we have? So it was, the notion of being appointed is misleading. It was a job I applied for. There were 70 applicants and 10 people interviewed. And so I was wrapping up the job with Inner City Health Associates over COVID because I knew the funding, it was COVID funding. There was a bolus of COVID funding for the pandemic. And that bolus was sort of running out at the end of March of 2022. So I was also teaching a health policy course at U of T, a master's course. And one of my students did an analysis of the reinstatement of the role, and really was kind of exploring this, whether it was going to be tokenistic, how it would be reinstated after an 11-year vacancy. And I had already, of course, knew that it was being posted. And so I applied, really not thinking I would get the job. And then when I was offered the job, then I had to pass the secret security clearance, which was like, there's 3 levels. There's reliability, secret, and top secret. And I'm not sure what top secret is. It's probably like a blood sample or something, but like secret was, maybe other people know, it's pretty invasive. But the secret was no joke. And so you have to, of course, declare all your conflicts of interest, potential or actual, and lots of detailed information on your family, including my dead brother, and so pretty invasive. And then I started, actually a lot of people don't know this. So I started on August 8th, 2022, and the ministerial announcement wasn't till August 22nd, 2022. So I couldn't tell Sol. I told my mom, but I couldn't tell anyone else. And I could only have internal meetings for those 2 weeks before I went to Ottawa for the announcement. So I couldn't scoop the minister's announcement. It had to be a federal minister's announcement. But yeah, it was a job. And working in the federal government is like an alphabet soup of acronyms every single day. I've been there 2 years and there's still like acronyms that I haven't learned. It's like people talking code. Everything has an acronym, including my favorite, which is CHAD, or Canada Health Act Division. It's just a cute name for my colleagues who really study the Canada Health Act. Everything is very bilingual as well. So we have a requirement to our official language policy. So if their preferred language is French, we have to conduct meetings in French. And at the executive level, it's not uncommon to flip back and forth in meetings very seamlessly, and to use sort of French words here and there, sort of interspersed throughout a meeting. And then I think the other piece is the powers or levers that we have. So as I mentioned, healthcare, this is really an interesting sort of, I think, phenomenon in a school of nursing, because healthcare is funded federally and managed by the provinces and territories, but post-secondary is entirely the domain of the provinces and territories. And so we have a bit of a disconnect when you think of those bi-ministerial priorities. And when it comes to health and our domestic production of nurses, for example, we need to actually marry the two and think about it, you know, from a pan-Canadian perspective. So a lot of work, working very closely with the provinces and territories, and then the sort of national associations as well. It's a cool gig.
Yeah, that sounds very interesting, the clearance process. I have some war stories of my own from going to the NIH. It's very interesting. Okay, so, but enough about that. What about this question? What are the systemic constraints that you've encountered while trying to deal with the nursing shortage?
I think the systemic constraints, I think contextualizing it. So we don't have enough nurses in Canada. There's not enough nurses around the world. We will probably never have enough nurses in our lifetime. So thinking about, how we reframe this, we also have a number of nurses who have sort of exited the public healthcare system, are working for travel agency nursing, travel companies, travel nursing or agency nursing, agency staffing. And so, it shows us that we actually don't have a shortage of nurses willing to work. They're just unwilling to work in the public sector. So thinking sort of critically about that. The other piece is the data piece. We say we have 477,000 nurses in Canada, but we know we're actually counting nurses twice and three times if they're licensed or registered in more than one province or territory. So we actually don't have 477,000 nurses in Canada, maybe 400,000, maybe 350, I'm not sure. How many do we need? I think that is the perennial challenge. So we have proxies for measuring shortage, we have vacancy rates, we have sick time, absenteeism, and the other metric that's used sometimes is nurse per capita, which is sort of an OECD metric, but we can't really use that metric in Canada when you think of our geography, right? So if you think of nurse per capita, how does that work in a territory like Nunavut, which has a population of 40,000 but covers 3 time zones? You can't do a nurse per capita calculation. It's very different in Ontario, for example, with 40% of the Canadian population living very close to the US border. So I think that my approach to addressing the nursing shortage is actually to focus on how we're valuing nursing work. And that really is the work of the retention toolkit, and thinking about a strategic reorientation in how we're valuing the essential work that nurses do, and really focusing on structural and organizational level change that's needed in how we're valuing the nursing workforce.
That's great. So question for people who have children. How do you actually do work-life balance in such a huge role as yours, and then also being a mom? Do you have any tips?
Oh gosh. Well, you saw the eye roll picture, did you? The picture, I get a lot of eye rolls. My son thinks I have the worst job. He's 14 now. But I think it's where you rely on your family and community. I couldn't do this job without the support of my mom, who's a retired nurse, who kind of looks after the kid and the dog when I'm traveling. Our work is hybrid. So I didn't have to relocate to the national capital for this position. I work out of Toronto, from home when I'm not on travel status. And I don't think you balance ever. I think it's more juggling. You just have to figure out what ball you're going to drop and what else you're going to keep juggling.
That's great. And, doing the best that you can. So whatever you're doing is the best that you can. And it's one step forward at a time. So this is a good question. We've just recently in British Columbia increased we at UBC have doubled our nurse practitioner intake program. And is there work being done across Canada or in or in British Columbia, where we're trying to fully integrate nurse practitioners and things like nurse practitioner-led clinics and nurse practitioners in primary care and team-based care, all that kind of good stuff?
It's a good question. So we are, maybe one of the little things I'll mention is that we are hoping to issue the 4th interpretation letter on the Canada Health Act. I'm told the first one didn't count, so it is the 4th one, but if you don't count the first one, it's only 3. But Minister Duclos, who's a former federal health minister, wrote a letter, he penned a letter to the provinces and territories last March 9th of 2023, and it's publicly available, where he basically mentioned that he was concerned about patients being charged for virtual care. So the Canada Health Act stipulates the requirements for medically necessary services, and virtual care is, of course, a means of providing primary care. So he expressed concern at patients being charged for medically necessary, what's called physician equivalent services. This is a 40-year-old act, the Canada Health Act. And so our ways of showing that we're modernizing the act when there's been a big evolution in healthcare is through interpretation letters. So we still will be issuing an interpretation letter, partly for virtual care, but also for who could be considered a provider of medically necessary physician equivalent services. And I think that actually paves the way for different models of care, really under the leadership of nurse practitioners. We've seen a model emerge in Alberta where nurse practitioners can bill their provincial plans directly. And I think when we think of the millions of people in Canada without access to primary care, we really need to think about the key role that nurse practitioners play. So keep doubling your enrollment, please.
Well, and I'll just add a plug for nurses, of course, because nurses have a lot of work and they're very valued also in primary care. And I've heard that nurses are opening up their shingles in Ontario to provide care that isn't being provided in other places. So they're also a very important part of primary care. But we'll look for the letter. I can't wait to see it. Please send it my way. There's another question here that I think is around Sally Thorne being a legend. And so how do you combat imposter syndrome? Because, we all do this sort of comparison thing. I'm not doing enough clinical, I'm not writing enough publications, et cetera, et cetera. So what's your advice for combating imposter syndrome?
First of all, Sally Thorne is a legend. Let's just all agree. And an incredible nurse researcher and human. And I think we've all benefited from her tremendous leadership in Canada and around the world. In terms of the imposter syndrome, I don't know that I have an answer. I think that, we do things that we don't think we're worthy of doing, but we do them anyways. And I think you have to think about the role that you're in at a particular time. I won't be the chief nursing officer forevermore. I won't always be in this time and space and role. And so while I'm in this time, space, and role, I want to fulfill the role to the best of my ability and fulfill the role in the only way I know how, which is bumbling along as a vulnerable human. And so that's not everybody's cup of tea, but that's kind of how I lead. And I think try to combat the imposter syndrome of just being very human in the role.
That's great. That's really great. Okay, so I have a question. I know I'm kind of jumping all over the map, but I'm kind of trying to follow the Slido questions. So the next question is about your thoughts on nursing ratios. Do you have any thoughts about nursing ratios?
Well, not only do I have thoughts on ratios, but nurses across the country have thoughts on ratios because it's probably one of the top questions I get. They say, tell me about the ratios in BC. So I think this was obviously historic for BC to implement nurse staffing or nurse-patient ratios. And, it showed a tremendous collaboration between the BC Nurses Union and government in implementing ratios as a means not of addressing workload, but of addressing quality and safety, because we know that's really what it's about. It's really not about having an inordinate number of patients. We know that patient care suffers when nurses aren't able to provide adequate care. We also know people are sicker. And so when they aren't able to get that continuity of care or that good quality care, they boomerang back into the system, and we pay for it in terms of morbidity and mortality. And so ratios are really sweeping the country, I will say. Nova Scotia recently adopted a safe staffing framework in their recent round of bargaining, not called ratios, but safe staffing framework. And it's something that I think we'll probably continue to see. So safe staffing frameworks is one of 8 recommendations in the nursing retention toolkit. And so we have funded the Canadian Federation of Nurses Unions to host a nursing ratios summit in November to really look at this issue from a Canadian context, look at the literature internationally, and sort of see how it may play out in our Canadian workforce.
Okay, thank you. Okay, so the next question is something that's happening in British Columbia. So it's about mandatory and forced treatment for addictions is a contentious issue in the BC election. Can you talk about this approach from a nursing policy perspective?
All right. You guys are political already. I mean, I would just say that we need to really interrogate, like, what else do we force? Do we force a healthy diet for somebody who needs cardiac surgery? What are some other things what are analogous comparisons in healthcare? And I think we'd be very hard pressed to come up with a single one. And so really thinking about, I certainly get the argument. I wanted my brother to stop using drugs. I wanted him to be abstinent and get his life together when he was alive. But if the alternative is death, and I never, forced treatment was not even on my radar and still isn't. If the alternative is death, I think, we meet in the middle then in terms of harm reduction. And that's what I think is on the continuum. And, my personal view is I don't think anything forced is on that. But this is where ideology comes in and trumps evidence. And so thinking about it, I think from an evidence-based perspective and how harmful it could be and have the unintended consequences. And really thinking about, our carceral system. So that is a forced model, right? You commit a crime, you go to jail, whether it's your provincial jail or a federal jail, depending on the crime and the sentence, and how harmful that is. So I think I had the misleading assumption that when my brother was incarcerated, he fattened up, he got a bit of weight on him, he worked out, he read books, he wrote letters to his children. And I really underestimated the re-traumatizing effect of every single time he was incarcerated and how that was compounding his trauma. And so I can tell you that in all of the people I've cared for from the park to present day, every single one of them has tried a rehab treatment program multiple times. And I think the nut we have to crack is the fact that many are abstinence-based and they're actually not harm reduction focused and they're not community-based interventions. And so really thinking about how much treatment we're funding that is not evidence-based, that is really based on, ideology or, I don't know, a retreat in with horses or something. Not anything wrong with horses, but we're not really looking at treatment from a harm reduction lens and from an evidence-based lens. So I think, this is one example of forced mandatory treatment that could have devastating unintended consequences. And I think our perspective on that as nurses is to bring the evidence to bear on that policy choice.
Yeah, that's really great. Can you come and teach for me? Okay, so I have a question here. I think it's maybe from a student. What advice would you give to students who are brave enough to speak up when there are systemic issues or pressures that are trying to keep the status quo? So how can they find their voice in a way in a system where it seems like, we're trying to keep the status quo?
I mean, that's our job as faculty, right? Like, we need to protect students. I've heard every horrible example of, students having to heat up their preceptor's lunch and all kinds of very, very demeaning ways in which we're treating students. So students absolutely need to be the voice that is raising issues, but they need to be protected in doing so. And that means I think that's very tricky for educational institutions because they have to ensure they're protected in the clinical environment too, in the service side of health professions education, not just in the academic. Because you may have rules, around whistleblower protection, for example, in the academic environment that doesn't actually transcend to the clinical environment, but it's the clinical environment where they're actually going to be seeing and witnessing those structural and systemic issues. So they just absolutely need to be supported and protected.
Okay, next question. Does it feel like a dissertation all over again? Dissertation defense? In nursing education, how can we teach nursing leadership in a politically savvy, nursing-focused approach and not simply a leadership and management approach?
Well, I think we all need to read Mike Villeneuve's book on nursing policy because it's a great book. And it's really about nursing leadership. It's obviously a policy book. So, but I think it really does speak to the nursing voice being embedded in policy and decision-making. And that is leadership. And leadership, in my view, is how you show up every day in the world. It's not about your role or title. And that's a choice. And I think having some tools in our toolbox, like Mike's book, are really helpful for really navigating that tricky terrain.
So kind of a related question to policy is around the public and privately funded healthcare system. Do you see a role in Canada for both private and publicly funded healthcare, or will this lead to a potential collapse of the system?
I mean, I think it's hard. I think I'm speaking on this topic in November, so I wasn't prepared for it today. But I think that nurses bring a really important health equity lens. And so that's something to consider when it comes to privatized healthcare. We have essentially developed our healthcare systems in Canada based on, again, medically necessary services, not on the ability to pay. And so those are that's the principle of universality, which of course we wouldn't have in a privatized system. I think it's, nurses have to play a really important brokering perspective if we are navigating that divide, because we, again, want to ensure that what we're providing is from an equity lens, but also from an evidence lens. So would it collapse the system? Hard to say. I think from a federal perspective, our only lever is the spending power when it comes to healthcare. So that means that if patients are charged for medically necessary services, our power under the Canada Health Act is to impose deductions, essentially to say that, patients were charged for these things that are medically necessary, and then the provinces and territories that are charging patients need to give money back federally. That is really the lever that we have. But otherwise, it's up to the provinces and territories, and that is enshrined in the Constitution in terms of healthcare delivery. That's the dance of federalism that we play every day in Canada.
Yeah, that's really interesting. Okay, I have a question for you around new nursing roles. So nurse anesthetists have been implemented in the US. Is there any dialogue in Canada around the nurse anesthetist role, knowing that this is also being fairly politicized?
I think I would say it depends who you ask that question to. So there is no dialogue of that role with the regulators. There is really a move to more generalist practice. The NP changes in NP education this past September were really around sort of level setting the NP role at entry to practice to be more generalist. But I will say from a policy perspective, there's a heck of a lot of dialogue about the shortage of anesthetists. And so I think there's a question there, right? There's a policy gap there. And I think at this point in time, I think, you know, if that's a role that would fill a gap, then that advocacy needs to, you know, move up to all levels. I would say there's very isolated conversations on nurse anesthetists at the moment. But again, from an access perspective, we know that it's not just about surgical wait times and, you know, trained nurses to work in ORs. It's also about shortages of anesthetists. So thinking about, I think that new roles will emerge. And my worry is that if nursing doesn't get ahead of a lot of these changes, we're going to see different roles. We've seen incredible movement, I would say, in pharmacy and paramedicine across the country. And so, you know, and often physician assistants are favored over nurse practitioners in some jurisdictions. So really thinking about what is the nursing lens, what's the nursing perspective around the whole perioperative continuum that nurses could bring into that gap.
Okay, folks, that was your call to advocacy. So we need you to come forward. Okay, so how do you plan to advocate for planetary health?
Is that Raluca? Well, I think the planetary nurses are the coolest new group of nurses that are emerging, certainly onto my radar. And I think, I mean, we certainly have talked about this, but I think it is not just about greening healthcare and like zero procurement, but also somebody, I think, mentioned this today about nurses evacuating, you know, in the event of fires, floods, all the apocalyptic weather-related emergencies we've had and how traumatizing that is. You know, we had I think an historic event where we evacuated a capital city of Yellowknife. We evacuated the Stanton Memorial Hospital. They, which was also the long-term care facility. They called in the Army. The Army won't go if there's no functioning emergency department. So folks were evacuated and then they realized, well, we still needed to run the emergency department at the Stanton Memorial Hospital. They still needed pharmacies. You know, animals moved into the city with all the folks going out of the city. But, you know, we haven't really looked at the nursing role, and it's because in the Northwest Territories, in actually all of the territories, weather-related emergencies and other disasters are very common practice. So floods, fires, plane crashes, all of these things are very common, as well as suicide, homicide. All of these things happen with alarming frequency. But in terms of the question around planetary health, I think we need to actually marry it with workforce and think about it from a workforce perspective. And that's maybe a little call to action as well.
That's great. Okay, so I think we're gonna probably call the time, but do you recall the name of Michael Villeneuve's book? If you could just repeat it for the audience. Oh, is it up there? Okay, perfect.
It's right here.
Right, okay, perfect. Okay. Yeah. Any last tips for our audience today in terms of health policy, advocacy, the things that you've been very involved in moving our country forward, and Canadian nurses?
Well, I mean, I think we need to stick together, you know, and be united in having a very strong nursing voice in Canada. And there's many things that we can't take for granted. We can't take for granted, you know, that we are going to have a seat at the table, that we are going to have a representation in provincial and territorial governments as well as federally. And I hope that some of you are interested in policy, because I think it's a really interesting area of nursing. And it wasn't until this role that I was able to actually see the common thread of policy throughout my entire nursing career. And so I think, you know, we also need to think, when I started in this role, I was still working very regularly in a supervised consumption site. And so we have to also think about like not abandoning clinical practice necessarily for other roles. We can do multiple things. We are the MacGyvers of the system. So there's many things that we can do. I really want to thank you for having me and for indulging me in a very personal presentation. I know that I could have come and talked all about the role, but I do that all the time. And so I think that sometimes as leaders, we have to talk about our journey as well. And so that's really what I wanted to impart tonight. But you all have stories to tell, and I encourage you to share them as well.